Alright, let's get started. Happy Tuesday. Kind of. Alright, I want to turn to page 10. Let's start on page 10. Page 10. Okay, last week we started relaxants, and so I'll backtrack just a little bit. And I started by saying let's first talk about monitoring and how we determine what percent paralyzed somebody is and so on. So we spent pretty much the whole time, almost the whole time, talking about the neurostimulator tests and signs of paralysis, etc. And on page 10 is a summary of the test. First, simplest and least information you get, but nonetheless it's there, is a single twitch test. And that's a single twitch at 1 hertz. And the patient moves or doesn't. If they don't move, you assume they're paralyzed. If they move, they're not 100%. And that's all you can really tell from that. Train of 4, of course, is the most popular. That being a series of 4 twitches every half second for 2 seconds at a frequency of 2 hertz. And you look at all 4 twitches and compare them. You see whether you have fade, and you can tell between 70 and 100%. If you have no twitches, you're 100%. You have 1 twitch, you're in the 90s. 2, you're in the 80s. 3 or 4, but less than a train to 4 ratio of 90%. You're in the 70s, and if you're a trainer 4 ratio better than 90%, in other words, all 4 twitches look pretty much the same, then you're less than 70% paralyzed. The next one down is DDS, and that's analogous to the train of 4, except for you just use 2 twitches at a greater frequency of 50 hertz, separated by 3/4 of a second. Compare the first and second twitches and see if you have any fade. Tetanic stimulation, of course, is the highest frequency, usually done at 100 hertz for 5 seconds, and you see whether the contraction is sustained or whether you have fade. And if it's sustained, that's a good sign. Well, the textbooks say then you have to be less than 50% paralyzed. I say you're minimally paralyzed. If you have, I'm not disagreeing with them, I'm just saying that it's even more of a sign than that. If you have a good tetanus that's sustained for 5 seconds, you probably have very little paralysis around, and that's a good sign of recovery. And then lastly, the PTC, or post-tetanic count. If you have none of the tests working, you want to know how much trouble you're in, how long it's going to be before the patient has any response at all to any stimulation, then you can do a PTC, and the post-tetanic count is predicated on the fact that when you do a tetanus 50 hertz for 5 seconds, you're mobilizing a lot of acetylcholine, and for a few seconds after you stop pushing the button, there'll be extra acetylcholine in the hand, in the synapse, and you can then do some twitches and get a post-tetanic facilitation. In other words, you can get a twitch when you normally wouldn't, just for a few seconds. You count how many you get. If you get up to 8, then the train of 4 should start to work. If you get 1 or 2 or 3, then the patient's pretty paralyzed. You probably should put the patient on a ventilator. Let the drug wear off. It's going to be a good half hour before they have any response whatsoever. So that's kind of where we went through the last time, and I'd be more than happy to talk about any of that. We're going to revisit some of it a little bit next week when we talk about reversing, because we have to, of course, use neurostimulator test among that, and the important, very important also, match that with clinical signs of recovery to make a judgment whether you can extubate somebody or not. and we'll get into reversal and stuff next week. So if there's no questions on that, then I'll move on to bigger and better. Let's go to page 31. All right, we're going to start with sucks. Let's talk about succinylcholine. The drug everybody loves to hate. Can't do without it. Well, you can't do without it. It's easier not to do without it. All right, page 31. All right, here's the chemical structure of sucks. Pretty simple. It's just two acetylcholine molecules stuck together. And if you note on my little diagram here, there's acetylcholine, top of page 31. And then when you stick two acetylcholines together, you get succinylcholine. So that's why it behaves very much like acetylcholine in the sense that it depolarizes and contracts the muscles before it spends a short period of time, 5 or 10 minutes, waiting to be metabolized, and during that time you're paralyzed. So sucks is a pretty unique drug because it's an agonist first, then it's an antagonist for about 5 or 10 minutes, then it goes away. So it's kind of unique. On the next page, 32, there's the metabolism of succinylcholine, and of course you know by now from other classes, and me probably touching on it a little bit last semester, but succinylcholine is broken down by cholinesterase. So in this little diagram here, they have succinylcholine acted upon by plasmacholinesterase, and it's a two-step process to break it down. The first step is you break one of the choline molecules off one side, so you end up with succinyl monocholine and one choline released, and then cholinesterase continues to work, taking on out to work, and you end up with succinic acid and choline at the end. They're both natural occurring chemicals in the body. There's no toxicity. Succinic acid is part of the Krebs cycle, and it goes on to make CO2 and water. And the choline that's released is actually has a reuptake mechanism. Choline is taken back up into the nerve and used to synthesize more acetylcholine. So you reuse the choline released to make new acetylcholine, and the succinic acid gets metabolized. Now, acetylcholine is question.
Yeah, is the succinyl monocholine, does it produce any paralysis?
Yes, succinyl monocholine, the first metabolite, has about, depending on what book you read, about 1/10 the potency of succinyl dicholine or succinylcholine. So yes, buildup of succinyl monocholine could extend the paralysis several minutes. But it has some activity, which normally doesn't play a role clinically, unless you're given a lot of sucks. So as I write here on the bottom of page 32, the brief duration of sucks is due principally to the rapid hydrolysis. You add water to it by sped up by plasmacholinesterase, and the succinic acid and choline are both inactive. So that's pretty straightforward. Now, let's go to the next page, and let's talk about cholinesterase. Because there's a lot of confusion about cholinesterase, so let's put that to bed right away. Say what it is, what do you call it, what does it do, etc. Okay? So, let me say this first of all, before you read it. Cholinesterase is the most ubiquitous enzyme in the body, and it's in there. Its primary role is to break down what are called choline esters, something that's an ester of choline, like acetylcholine. Its primary role is to break down acetylcholine, but it breaks down other choline esters. And it does it by hydrolysis, adding water, and speeding up these reactions. So cholinesterase, no matter what you call it, no matter where it is in the body, all does the same thing. Acetylcholinesterase, pseudocholinesterase, whatever cholinesterase you want to name it. Cholinesterase is cholinesterase. Everywhere in the body, it functionally does the same thing. It breaks down hydrolysis, choline esters. They're called isoenzymes. When you have isoenzymes, you'll have more than one form of the same enzyme. They are anatomically different. They may be locationally different, but they're functionally identical. There's examples all over. CPK, all kinds of enzymes in the body that have different isoenzymes, but they function exactly the same. So let's take a look at this on page 33. Oh, I forgot to say my second part. So what happens is this. The way it's evolved, terminology-wise, is that since cholinesterase is so common and it metabolizes so quickly in many things in the body, they have evolved the terminology to be, if something's broken down by hydrolysis in the body, the first thing they do is look at cholinesterase, because that would be the logical thing that would be breaking it down. It's in all tissues. If it has water in all tissues, so the substrate's there, it's very easy to work. So the first thing you look at is cholinesterase. If it's not cholinesterase, then the drug world names it non-esterase dependent. So it's either cholinesterase or other, is basically what I'm saying. If it isn't cholinesterase, then we just say it's other. Other is a non-esterase dependent hydrolysis. In other words, it's non-esterase, it's not cholinesterase. It's something else. We'll talk about something else in a minute. So it's always going to be listed as one or the other. It's cholinesterase or it's a non-esterase dependent hydrolysis. Okay, now follow me here. Let's look at the top of page 33. Esterase enzymes. Ester compounds are metabolized by adding water. The process is referred to, of course, as hydrolysis. The basic reaction is if you add a water molecule to add an ester compound, you end up with an acid and an alcohol, whatever you use to synthesize it. 3 esterase enzymes exist in the plasma. They can all act as catalysts for hydrolysis reactions. They are the granddaddy of them all, cholinesterase, and also peroxidase and albuminesterase. So there's 3 types of esterase enzymes. Peroxidase and albuminesterase are referred to as non-specific esterases. So that's the other part. Either it's cholinesterase or it's other. Other being peroxidase or albuminesterase. But we don't even go that far. We just go non-esterase. It's cholinesterase or it's non-esterase. Done. Red blood cells contain 2 esterase enzymes in their cytosol, inside the cell, red blood cells. One is referred to as an RBC esterase, esterase D or S formylglutathione, or the other is a small amount of cholinesterase. So RBCs, red blood cells, actually have a non-specific esterase in them, and they also have cholinesterase. Okay, so let's say it one last time, then we'll get into all this. There's 2 various forms of esterase enzymes in the body. The granddaddy, the main one, is called cholinesterase. If it's not cholinesterase that's causing or catalyzing the metabolism, then we just say it's a non-specific esterase. Right. But I'm going to say what the non-specific esterases are. Probably won't say it again after today ever. But the non-specific esterases are peroxidase, albuminesterase, and RBC esterase. And they're the non-specific. We can just call them non-specific from now on. So either something's going to be broken down with cholinesterase, or it's going to be broken down with one of the non-esterase dependent drugs. That's as far as we have to go. Does that make sense? Okay, let's look at cholinesterase. Now, here's the confusing part. Well, it's not confusing, but I'll unconfuse it for you. Page 33, under cholinesterase. Cholinesterase is a generic term used for a family of related enzymes or isoenzymes. They all have the same function, just different locations and structures. that hydrolyze choline esters at a faster rate than other esters under optimal conditions. The major function of cholinesterase is to terminate the action of acetylcholine. So that's its primary role physiologically, although it does a lot of choline esters. There are two types of cholinesterase. The major function of cholinesterase is to terminate the action of acetylcholine at cholinergic synapses, and we've talked about that throughout the course. There are two types of cholinesterase in the body, with several variations and a confusing set of names. So depending on what book you read and whether it's British or it's from Asia or America, they use different names. It's all the same thing. Throw the names out. It's just cholinesterase. Okay? Here we go. There's two types of cholinesterase in the body with several variations and a confusing set of names. One type of cholinesterase is acetylcholinesterase. It's usually abbreviated ACHE. It's also known as true, specific, genuine, or type 1 cholinesterase. This enzyme is found in erythrocytes, nerve endings, lung, spleen, and the gray matter of the brain. It is a membrane-bound glycoprotein and exists in several forms. The other subgroup of cholinesterase is called pseudocholinesterase, and that's abbreviated PCHE. It's also known as plasma, serum, benzoyl, false, butyryl, nonspecific, or type 2. Got a headache yet? Right. We're not going to care. It's just acetylcholinesterase or pseudocholinesterase. Okay? But I want to show you. Pseudocholinesterase is present in the liver, smooth muscle intestines, pancreas, heart, and the white matter of the brain. Measurements of pseudocholinesterase activity can serve as a sensitive measure for the synthetic capacity of the liver. Why? Because cholinesterase is made of the liver. So if you have liver disease and it's not working, you're not making cholinesterase, your levels are going to go low, and that's a good way to measure whether you're liver disease, among other things you can measure. In the absence of known inhibitors, any decrease in activity reflects impaired synthesis of the enzyme in the liver. A moderate decrease, 30 to 50%, is seen in acute hepatitis, long-standing chronic hepatitis, and severe decrease, 50 to 70%, are seen in patients with advanced cirrhosis and some liver cancers. Decreased levels of pseudocholinesterase are also found in patients with acute infections, usually severe sepsis, pulmonary embolism, muscular dystrophy, MI, pregnancy, and after certain surgical procedures. Essentially normal levels are noted in chronic hepatitis, mild cirrhosis, and obstructive jaundice. Increased levels have been observed, but it's not going to matter clinically. If they have more cholinesterase, you're just going to see the same thing happen as if they have normal cholinesterase, so it's kind of academic. Patients generally develop neuromuscular symptoms at about 60% of normal activity. You can have a 40% decrease in cholinesterase and you won't see any difference in the patient's physiology. If they have less than that, then they're going to start to have muscle weakness. Serious neuromuscular effects at seen are about 20% normal, and the reference intervals are 29 to 7100. So that's it. Again, I'll say it one last time to summarize. There are several enzymes in the body that can hydrolyze esters. The main hydrolytic enzyme is cholinesterase. And cholinesterase is referred to as in two different forms: acetylcholinesterase in the synapse in the muscles, pseudocholinesterase in the plasma, and elsewhere. If it's non-cholinesterase that does the hydrolysis, then it's called a non-esterase dependent hydrolysis, and the enzymes that do that are oxynase, albumin esterase, and RBC esterase. Okay? Is everybody with me now? Good. So on the bottom, I summarized esterase enzymes, page 33. Number 1 is cholinesterase, acetyl and pseudo, and there's non-specific esterases, RBC, peroxidase, and albumin esterase. Okay? Now, take a look at the next page. This is a table 1 here on the top of page 34. Clinically relevant compounds hydrolyzed by human plasma esterases. And they go to show you all the different drugs that can be broken down by cholinesterase, peroxidase, albumin esterase, etc. And you see there's a whole table, and who cares, we're not going to learn it, but I just want to show you that you can in fact outline the drugs that are hydrolyzed, which enzyme group hydrolyzes them. This is from Biochemical Journal, Pharmacology Journal. And then I've put on the bottom, summarized some of the anesthesia-related drugs, the ones that we care about, in which esterase enzyme breaks it down. So some common anesthetic-related drugs that are esterase dependent, that's the bottom of page 34. And of course there's succinylcholine, which is broken down by pseudocholinesterase, mesocurium, pseudocholinesterase as well. That's the non-polarizer. All the ester-type local anesthetics, which we're going to cover next after the relaxants. And that's cocaine, procaine, chloroprocaine, and tetracaine. And they're all broken down by cholinesterase. Of course, neostigmine and edrophonium work by inhibiting cholinesterase, so they obviously are broken down by cholinesterase. We'll talk about that next week. And then, as far as non-specific esterases, atracurium, cisatracurium, remifentanil we talked about last semester, remember? And you have to give it by infusion, and it's so short-acting. And the reason is it's broken down by non-specific esterases. In fact, we want to be more pharmacologically correct, and I always do, then it's RBC esterases that break it down. Clofidipine is a calcium channel blocker, IV drip, they use in ICUs now, like a nipride or nitroglycerin drip kind of thing to drop blood pressure down. That's broken down by non-specific esterases. Azomalol, beta blocker we'll talk about after the relaxants, the locals, RBC esterases. And then the new form of midazolam that's under clinical testing, it may come out sometime soon. It's called remimazolam. It's an IV infusion. You have to give it by continuous infusion. It's essentially Versed that lasts about 5 to 10 minutes that you have to give by infusion. You turn the infusion off, it goes away. And that's because it was designed to be broken down by non-specific esterases. So these are our drugs that we deal with on a fairly frequent basis, and which form of esterase works on them. Okay? Everybody with me on that? I know there's a lot of names and it can be confusing, so I'll be happy to go through it again if you want. Okay, let's go to page 35 and let's talk about cholinesterase some more, in the sense that I want to talk about cholinesterase differences in people. So, so don't write, just listen, let me talk. There's in fact, it was one of the first, a lot of people contributed to the first pharmacogenetic thing that we knew about drugs and genetic influences and so on. And that's referred to as somebody having atypical pseudocholinesterase. I'm sure you've heard the term batted around in the anesthesia world, so let's study what it is and what exactly it isn't. So what happens is this. The world population, people are different. They have different enzymes in our bodies too. Different ethnic populations have different enzymes. different people, just in the same ethnicity, have different enzymes. We're just different. We have different color hair, we have different color eyes, we have different stuff. We have different enzymes in our body too. Different forms of the same enzyme, I should say. So we have cholinesterase, but some of us have different forms of the cholinesterase in the body, or different subtypes. Right? So in anesthesia, what we've done, or in medicine, really, in the bigger picture in medicine, we've noted that there's a small subgroup of people who have a different type of cholinesterase. We call it atypical. It's not the usual, it's atypical cholinesterase. And if you give them ester drugs, they can respond differently because they can't metabolize it the way a typical person should. Right? It's not a disease. It's not a disorder. It's just they're different. I'm going to pick on people, I apologize. It's like having red hair. And it's not as common as the rest of us. Of course, mine's gray. What I have left. But it's normal. All right, there's nothing, it's just different. All right. Atypical cholinesterase. It's not a disorder. Their enzyme is perfectly normal for their body. In fact, if they don't go and have surgery and get succinylcholine, they'll go through their whole life and never know they had atypical acetylcholinesterase. The only reason they know is because you gave them sucks and discovered it. But for their body, everything's perfectly normal. They have a normal, happy life. Now, that's an issue because I'll give you the clinical scenario. Here's what happens. You go to work, patient looks normal, patient is normal. Going to have a routine procedure, take them back in the room, knock them out, give them sucks, intubate them. Case starts. Maybe give a non-polarizer, maybe not for the case. They don't seem to come back from the sucks. They don't start breathing after 5 or 10 minutes. They seem to be staying paralyzed. Case goes on for an hour and a half. At the end of the case, you try to get them back breathing. You got rid of the narcotic, you blow off the gas, you try to reverse them, and you got nothing. They're still paralyzed. They're weak, they can't breathe, they're not responding appropriately. So you go, oh, that's not normal. And you say, I wonder why. So you order a respirator, you take the patient to the recovery room, you put them on a ventilator, you give them sedation so they're not awake paralyzed, and you wait. And you wait to see when it wears off. Maybe 6, 8, 10 hours go by. Usually they say that excess atypical at the outset will take maybe 12 hours at the most. Usually they'll wear off within about 6 or 7 hours. So, after 6 or 7 hours, the patient gets their strength back, they start breathing, they get extubated, they go home. Or they're ready to go home. So you say to yourself, what happened there? That's not normal. They just came for a routine operation. I gave them sucks like I've done a zillion times to everybody else, but they couldn't wear it off. Now remember, succinylcholine will always wear off on its own. Enzymes don't cause reactions, they just speed them up. You don't have to have any cholinesterase in your body to metabolize sucks. It just takes a lot longer. Instead of metabolizing in 5 or 10 minutes, like we hope, or we should, it may take 6 hours or 7 hours. So the enzymes aren't causing the reaction, breakdown of sucks, they're just speeding it up. So before you send the patient home, you say, I wonder why they had such a prolonged effect of the relaxant. Some people, you'll see some old timers or clinicians will say if you give sucks, you intubate, and then you're going to give a non-polarizer for the case, which it happens very often, daily, then you should try to see some recovery from the sucks before you paralyze the patient with a non-polarizer. A twitch back on a train of 4, maybe a little bit of a breathing, something. Blinking their eyes, whatever you can see. Because this way you can say to yourself, well, I see the sucks is wearing off. Then I go ahead and give the non-polarizer. If they don't recover at the end, I know it's the non-depolarizer, not the sucks. Because they were recovering from the sucks. You don't have to let them all the way recover. You just want to see some sign of recovery. All right, sometimes you can't do that. Sometimes the surgeon's rather to stick trocars in, and you haven't seen the sucks wear off yet, and you got to paralyze the patient so they don't come off the table. So you go ahead and give the rocket on him or whatever. Anyways, but if you can see some sign, that's a good thing. Right? So back to my patient. So my patient recovers and they're doing fine. I extubated, happy, ready, putting the shirt on, eating a cracker, getting ready to go home. And I say, I wonder why this patient didn't respond appropriately to the relaxant. I wonder if they have atypical cholinesterase. So I draw some blood and I do a lab test. It's called a dibukine inhibition number. That's the lab test you're going to do. We're going to talk all about it here. So we're going to do a dibukine test. And the patient's going to get dressed and go home. So there they are. So this dibukine test or any of this talk about atypical cholinesterase is not guiding care of the patient. Care of the patient is going to be separate from all this. Care of the patient is going to be keep them intubated, put them on a respirator, sedate them so they're not awake, and let the drug wear off. That's care of the patient. It's 100% effective. It always works. The patients will always be fine. They'll always go home happy. In the meantime, you're going to do a dibukine test. So you draw a couple tubes of blood, you send them to a lab. Depending on where you're working here at Kaiser, we're able to do that. Our labs are pretty big. In fact, the second biggest lab in the United States. But a lot of smaller hospitals where you work maybe can't do a dibukine test. They send them out to a central lab and have it done, so it may take 2-3 days to get the results back. So you're going to get results back, and we're going to talk about how you interpret the results here in a minute. The results are going to tell you whether the patient is atypical or not. Now, if the patient is atypical, then you're going to want to do some genetic counseling and call them at home and say, you know, you had a prolonged response to whatever anesthetic drugs. We just want to let you know that if you have surgery again, make sure and you give them some counseling. Right? Now, you have to be careful. You don't want to call the patient up and say, well, we found out you got atypical pseudocholinesterase. They're going to think they're dying. Right? They're going to call a funeral home or something. Right? That's a perfectly normal thing. You have to call them up and tell them they're perfectly normal. Nothing's different. They're going to live a happy life. They just have a different response to certain drugs. And so give them some fair warning. Right? So that's the clinical scenario, the way it's going to play out. All right, so let's talk about the gory details. On page 35, I've listed in there are several different subtypes of cholinesterase forms. And let's read what I wrote. The top. Several tests for determining pseudocholinesterase variants are available. The most common is called the dibukine inhibition test. Now, dibukine is a local anesthetic that nobody uses anymore. And that's neither here nor there, it's just incidental. But it's used in a lab test. So what happens is you pull some blood from the patient, put it in a test tube, send it to the lab spins it down, and takes the plasma, and then takes dibukine and drips it into the test tube. And what you look for is the cholinesterase in the test tube inhibited by the dibukine the lab tech is putting in there. If you have I don't want to say normal, I'm going to stop myself. If you have typical cholinesterase, then it should be inhibited by dibukine. All of us, if I did a blood sample on everyone this morning in this room, sent it to the lab and said, do a dibukine test, our dibukine would be inhibited in the test tube. Our cholinesterase would be inhibited in the test tube by dibukine. That's usual. If it's not inhibited, then we say the patient has atypical enzyme. All right? And the dibukine number, when you get the lab result back, they give you the little lab slip with the results, or They call you on the phone, they post it on the computer, whatever they do. The number they give you is the amount of inhibition that happened in the test tube when they drip Dibukane into your cholinesterase plasma containing blood sample. The higher the number, the more inhibition, the more likely it is you have atypical. Right? We'll go through the numbers here in a minute. I just want to give you a picture of how it works. They'll also report a second value. And they'll tell you how much cholinesterase activity you just had in general. Did you have 100% activity? Did you have 50% activity? Did you have 10% activity? Whatever. The amount of activity that they report to you isn't what type of enzyme. You can have atypical enzyme and have 100% activity of that. Or you can have typical enzyme and have 100% activity of that. I assume all of us in this room have 100% activity of typical enzyme. But if I get a normal healthy person with atypical enzyme and I draw their sample, they're going to have 100% activity of atypical enzyme. So, they're reporting both numbers because they want you to know, number one, is it typical or atypical? And number two, is the patient's response prolonged because it isn't the type of enzyme, they just don't have enough of it. So this way you'll know both things. If they tell you this patient has 100% typical enzyme, but only 10% activity, then you can say, well, they got the regular enzyme, but they just don't have enough of it. Maybe they got liver disease. Some other issue. See what I'm saying? Let's go through this. Page 35. There's the enzyme. Most common, I'll read the top part I wrote here. The most common test is to do a Dibukane inhibition test. Dibukane inhibits typical or usual pseudocholinesterase, but not atypical. For example, the normal Dibukane number of 80 means that 80% of cholinesterase activity was inhibited by Dibukane in the test tube. That's normal. That's what you expect to happen. That's what all of us would. We'd have a Dibukane number of 80. That's normal. If the Dibukane number is 20, that means the patient had atypical enzyme. Since Dibukane did not inhibit the patient's enzyme activity. If a patient experiences prolonged apnea following sux or mivacurium, because mivacurium is also broken down by cholinesterase, as we'll talk about, and you have to differentiate. Number one, do they have typical or atypical? Or number two, do they just not have enough of one or the other? How much is their activity in general? All right, everybody see that? Let's go through this. Here's a table. Find this in any anesthesia book. Succinyl invariant is the first column. Usual. So the typical enzymes. Medicine people, pathologists who figure out all the names for this, they call it a usual enzyme. So if somebody's homozygote for usual, in other words, both mom and dad gave them a gene for the regular cholinesterase enzyme, then they have EU, right? E meaning enzyme, U meaning usual. So they have both. Mom and dad gave them the usual enzyme. The frequency of this happening is 96% of the world population. All right, I'm reading across the top of this table. Their enzyme activity would be normal, and their Dibukane number would be 70 or 80. So that's the normal. You would expect all of us to do. All right, let's look at number 2 column. What if you're heterozygote for the atypical enzyme? In other words, you have one usual enzyme, EU, and one atypical enzyme. Either mom or dad gave you an atypical, the other one. So you have the trait, right? You don't have the atypical enzyme, totally, but you have atypical cholinesterase trait. That's the way genetics work, right? How often does this happen? About 3% of the population, 1 in every 480 patients. Enzyme activity would be decreased, and it would be slightly prolonged response to SUX, 50% increased duration. So the decay number would be in the middle, 50 to 69. SUX would last 50% longer if you have the atypical trait. Well, SUX is lasting 5 to 10 minutes. If it's lasting 50% longer, that means it's lasting what? Maybe 7 to 12 to 15 minutes maybe? I bet you're not even going to notice. In the course of induction, you're so busy taping and glopping the eyes and playing with the dials and getting the drapes on and getting the case started, as you should be, then you're not going to notice whether SUX lasted 5 minutes or 7 minutes, or 5 minutes or 8 minutes. In fact, you're going to think it just follows the normal, curve of responses to whatever the drug is. So you probably won't even notice clinically the patient has the atypical trait. Right? Let's look at classic atypical enzyme, the third one down. Then the patient's homozygote, they have both. Mom and dad gave them an atypical enzyme, E sub A, E sub A. This is about 0.3% of the world's population, or about 1 in every 3,200 patients. The activity is going to be decreased by more than 70%, and they're going to have a significantly prolonged response to these relaxants, anywhere from 4 to 24 hours, and their Dibicane number is going to be low, 16 to 30. Did you see that? One in every 3,200 patients. So I work at St. Mary's Hospital in suburban Arizona somewhere, and having my nice CRNA career. And they do about 10,000 surgeries a year in my hospital, routine little suburban joint. And 1 in every 3,200 of those patients are going to come in there with atypical. So how many are you going to see in your hospital for a year? Maybe 3. Hopefully they're going to be in somebody else's room. Not in yours, right? So you may not even see any. You just hear about Mary's case that ended up a mess. Although the patients you do fine as long as you act appropriately and put them on a ventilator and let them wear off. So that's the frequency of you running into this. Not a bigger hospital, city hospital, university hospital. Some big city, they may do 25,000 cases, 30,000 cases in all their little satellite clinics, etc. Well, maybe you'll see 5 or 6. Good. But I just want to give you a feel for how often you're going to run into this. All right, let's look at the second to the last one there on the table. It's called fluoride. There's some other subtypes of cholinesterase that are not typical, but it's not classically atypical. One is called the fluoride-resistant gene, and they're homozygote for E sub F. E sub F, that's 0.03% of the population. Nobody really knows exactly how many there are because it's so rare, and they are moderately prolonged. There's another gene called the silent gene. It's E sub S, 0.4%, 0.04% rare again. They have no regular typical activity, and it would be significantly prolonged, although again, the drug will always wear off, you just have to wait. If you do a patient and they have a prolonged apnea, and you do a Dibicane inhibition number, and the Dibicane number comes back normal, and so you still don't have a way to explain their prolonged apnea, you can just say, well, they must have had the silent gene. You sound really scientific, you'll have no idea what you're talking about. Because at that point, we don't really know. We don't test for it. Okay, so let's wrap it up here. Turn to the next page. This is a little graph, and maybe I'll go on the camera and point. I'm on page 36, and this is the frequency distribution of cholinesterase enzyme in the population. Thank you very much. And you can see this is a minutes to 100% twitch recovery. How long does it take to recover from SOX versus how much cholinesterase you have in units per liter. Normal cholinesterase levels are right here where the arrows are, between 8 and say 15, the way they're measured here is units per liter. So you see that if as long as their activity is normal, and they're banned here, or even if it's increased, it's still going to metabolize the same rate. They're going to break down 100% recovery of the twitch is going to take how long? Oh, 15 minutes max, right? Everybody see that? If they have less cholinesterase, well, let's say they're down here about 200 units per liter, then how long is it going to take? Well, it could take up to 22 minutes or 30 minutes or whatever. So in other words, the less cholinesterase you have, the longer it's going to take to break down cholinesterase. No mystery there. All right, so here's what, let's go to the top. I wrote this in here for you to summarize it all and make it all so easy. You're welcome. When you get a diabetes test done on a patient, and you get the results back, only 4 possible results can come back. This is it. I wrote them down for you. This is what they mean. All right. Number 1, if the patient has a low dibacane number, say their dibacane number inhibition is the dibacane number is 80. I'm sorry. Let's start again. The dibacane low number. That's what low means, right? The dibacane number is 20, which means that very little of their cholinesterase was inhibited by dibacane, which means it must be atypical. Because typical is inhibited, atypical is not. So if the dibacane inhibition was low, like Johnny says here, but they have normal activity, so they have 100% activity, the dibacane number is 20. Those are the 2 values your lab result tells you. All right. What does it mean? It means they have classical atypical enzyme. They'll have prolonged apnea. You'll do genetic counseling. You'll have a nice, interesting story to tell in the coffee room the next day, and it'll be fun. You can tell all the students you precept how you had a patient with atypical and you handle it like a champ. All right, so that's number 1. Number 2, what if they have a normal dibacane number? Say their dibacane number is 80. That means their enzyme is the same as everyone else, but they just have low activity. They got 30% activity. Maybe they got a bad liver. Maybe they're a drinker. They got a cirrhosis or something. I don't know. Whatever. That means they have normal enzyme, but they just have low levels. And they're going to have prolonged apnea because of the low levels. How low do the levels have to be? Well, remember in my 2 pages earlier, it said you got to be down around 30% or less to start to see really symptomology. Right? Number 3, you got a low dibacane number, so you have atypical, and you have low activity. Man, that's a double win. This patient's not going to recover for quite a while. Then finally you have a normal number, say your number is 70 or 80. You have normal activity. That means the patient was normal, and you better start looking for another reason why they spent 6 hours on a ventilator and recovered when they were having a knee operation because there wasn't a typical enzyme or anything to do with cholinesterase. Maybe something else happened. And of course, we're going to go through a list of what can happen, which is appreciable. Okay? Does that make sense? All right, let's take a break. Yeah, question.
So is succinylcholine contraindicated in patients with liver disease?
No. Because it's so rare that I don't think you would really have to worry about it. Okay, take a break. Okay, let's go to page 37. 37. Okay, enough of the cholinesterase. Page 37. Let's talk about side effects. These are really well documented and everybody knows about them, so let's talk about them and what happens when the gift sucks. So on page 37, number 1, side effect, of course, is hyperkalemia. So normally the common wisdom is that if you get succinylcholine, anybody, normal, abnormal, whatever, every patient who gets succinylcholine has a transient increase in plasma potassium of about 0.5 milliequivalent per liter. So if your potassium is 4.6, I'll just make it up, you give somebody sucks because they depolarize, and when you depolarize, sodium goes in, potassium comes out to repolarize. When the potassium comes out, for those 5-10 minutes or so, you have a higher level of serum potassium until the sodium-potassium pump puts it back where it belongs. And for that transient amount of time, you have an increase of about 0.5 milliequivalents per liter. So if your serum potassium was 4.6, I'll just pick a number, and it went up to 5.1 for 5 minutes and then went back to normal, who cares? Nobody. That's what usually happens. Right? However, if you have hyperkalemia already and you raise somebody's potassium, that can be an issue. And secondly, of course, if you have any number of physiological changes that may result in an excessive potassium release, not the normal 0.5 milliequivalent per liter, but instead you can release 5, 6, 7 milliequivalents per liter, then you got some problems. All right? So look at number 1 here. Normal serum potassium reading off the top of page 37. Normal serum potassium increased by about 0.5 milliequivalent per liter, secondary to potassium leaking from depolarized muscles in order to repolarize. In patients after crush injuries, this is somebody who got in a car accident, their legs got crushed by the dashboard, severe muscle damage of their legs, for example. Burns, of course, very important. I'll talk about them more in a minute. Denervating injuries, these are people quadriplegic, paraplegic, somebody who's had a neurological problem, MH, malignant hyperthermia, potassium levels may rise much higher. For example, there was, before we knew all this stuff in the 60s and so on, there was cases where a patient would come for neurosurgery after a quad injury, and they got sucks and their potassium went from 3 to 9 or something crazy like that in just a matter of a few minutes. So the clinical scenario is you give the patient sucks to intubate, and about 3 minutes later they get a cardiac arrest because the potassium released so high, causing hyperkalemia, and you know what that does to the heart, right? So it stopped. So that's why you have to avoid it in these certain types of situations. So that's the hyperkalemia. Number 2, arrhythmias. Well, every kind of arrhythmia known to man has been reported after the administration of sucks. Mostly they're benign. I can imagine you can occasionally get more severe, but it'll be once in a career type of thing. Usually when you give succinylcholine to somebody, they get slight tachycardia. In fact, I brought it out. Now that you put people to sleep enough, you notice that what happens to the heart rate when they go to sleep. It always goes up during induction, right? Give them propofol, give them socks, put a tube in. No matter what we do, every time we touch a patient, they get tachycardia. Hi, how are you? Oh, tachycardia. So, usually some degree of tachycardia. In children, they can get sudden, abrupt bradycardia from socks. We don't give it to kids. Or you can get sudden, abrupt bradycardia in adults if you repeat the dose. So let me pretend. This is your heart rate monitor. I couldn't get the tube in. I'll give another dose of socks. Go back and intubate again. Ventilate a few minutes. I give 40 more socks. I go back to intubate a second time. That's what you hear. Sudden abrupt bradycardia. It goes from 110 to 40 with that second dose of socks you gave. Okay? That's in adults. In kids, it can get sudden abrupt bradycardia in any dose. But again, we don't use it in kids anymore. We'll talk a lot about that. Some people you see, CRNAs, anesthesiologists, will in fact give a small dose of Robenol if they repeat the dose of socks. I think it's a little overkill, but to each his own. Second or third dose, maybe they'll give a little Robenol to prevent the bradycardia. Myalgia, next one down, sore muscles, and that's patient next day post-op feels sore when they get up to move around and so on. That's because of the asynchronous way that sucks depolarizes muscles. You get these little microscopic, you can't see them or feel them, but little tears in the muscle fibers because they're not contracting perfectly together, and that can cause some pain. That's why we pre-treat with a small dose of non-depolarizer first. It minimizes the depolarization fasciculations from sucks and helps minimize the post-op myalgia. It doesn't prevent it totally, but it certainly can make it less. Myoglobinemia, for the same reason. If they fasciculate, you can get some elevated intragastric pressure. When you depolarize all the stomach muscles, and I'm talking about stomach wall, rectus muscle, internal, external, oblique, etc. As the patient depolarizes and fasciculates, that squeezes the toothpaste tube, right? So you can get a elevated gastric pressure, transient, while the patient's getting paralyzed. We don't care. We use socks for rapid sequence on purpose, right? So this is kind of academic. You can get an elevated intracranial pressure if you use socks in a neuro case. Probably they speculate as the fasciculations of the neck muscles cause contraction of your veins in the neck, and they temporarily make your ICP go up a little bit. It's a classroom thing, nobody cares. Elevated intraocular pressure, same thing. Right, muscles fasciculate, depolarize, you can get an elevated intraocular pressure. Remember, we've talked about this 10 times already, I'll say it again. The two drugs we give, they can raise intraocular pressure, that's contraindicated in people with an elevated intraocular pressure are succinylcholine and ketamine. All right, MH, of course, you don't want to give sucks. That's the #1 trigger for MH, so that's an absolute contraindication. Take it out of the drawers and take it out of the room and don't give sucks. And then lastly, side effect of masseter spasm. If you give somebody sucks and rather than relaxing their jaw and you can get in tube in it, your blade in there and tube in and so on, you can occasionally, once in a while, it looks like their jaws are contracted. You can't get their mouth to open up. that like have a masseter muscle spasm in their jaw muscles. And usually it's probably you just can wait long enough for sex to work or whatever, but if it truly happens, then the MH Society of America says that's a premonitory sign that the patient may have MH. So if that happens to you and you go to intubate somebody and they get tight mouth, you can't get their mouth open, you can't get them intubated, you have to ventilate them with a mask and figure out what happened. That could be a sign of MH is going to happen later in the case. So those are the side effects from sucks. Okay, any questions? Good. Let's talk about contraindications, especially hyperkalemia and burn patients. So on the next page, don't write any of this down. Just listen. I'm going on the camera and point here. When I was working clinically in Detroit receiving, we have a burn. There is a burn center there. We did a tremendous number of burn cases. Industrial Detroit manufacturing town. We did a lot of industrial workers, and we had burn cases and so on. I was working one time, and a patient came into the ER, called us to intubate, and we found out the patient had I think it was over 90%. I know it was over 90%. I can't remember exact percent. Total body burn. He was in his 40s. It was an industrial accident. Fortunately, it was kind of odd that he had a headgear on, and so the burn was all below his neck. He didn't get his face or anything. But anyways, he ended up coming back to surgery for years, because in those patients, their injuries, they got to come from skin grafts and debridements and release of contractures, and I mean they're unfortunately set to a lifetime of surgery. So we got to know him and his wife very well, and so we asked him, when you are having, you come in for your surgeries, is it okay in whatever area we're doing the procedure that day to take a little piece of muscle and do a muscle biopsy? And he said, oh yeah. So actually Mary Walchik and Sam Pirov, their CRNA anesthesiologist, friends of mine, they both are still working in Detroit receiving, and they're fabulous anesthetists. Three of us did the study, and that's what this graph is about. And what we did is we found a guy up at Harvard who was able to measure how many cholinesterase receptors you had in a muscle. So we would do a muscle biopsy on this fellow and send the sample out to Boston, and the guy would report the amount of cholinergic receptors, and then we plotted it. I'll show you that in a second. Now, there's an old coffee room thing or a back of a napkin kind of calculation. In fact, there's several of them. I have a couple of them in my book in the chapter on burns. But one of them we generally use, most people use, a lot of people use, is if you want to know the mortality from a burn injury, third-degree burn, you take the patient's age and their percent burn, and that's the chance they're going to die. Right? This guy's 90% burned, 45 years old. So the chances of him surviving from this are essentially zero. But he lived, and he did well. And so it's a tribute to great physician and nursing care, and so it was a good thing. And as he came in, you'll see that these are days post-burn. The question we wanted to know is this is what, I forgot to tell you the whole premise, right? See, the thing that we always learned in anesthesia school is when a patient has a burn, of course, you have to be careful giving them sucks, because the burn injury damages the muscles under the skin that's burned, etc. The muscles are damaged. And so when you give sucks to a burning patient, they can release tremendous amounts of potassium. Nobody's arguing with that. That's a fact. But the question was, how long does it last? if a patient has a burn injury and they come for surgery 3 years later, are they still susceptible to getting hyperkalemia 3 years later? And even more importantly, and this is still a little bit of controversy, but not really, today, is if a patient gets a severe burn injury, like this fellow had a 90% burn, he hits the ER, then the first thing you do is intubate. No question about it. Doesn't even matter. You don't even have to know this history. Because you guarantee it, the patient's going to blow up like a balloon. They're going to get so much edema and third spacing and so on that they're going to have respiratory problems. Whether they had burn injury, respiratory part of the burn injury or not, you just got to intubate them. That's a given. And so the ER docs will say, well, can I give sucks to intubate? The patient just had a burn injury, 45 minutes ago, throw him in an ambulance, rush him to the hospital. Can I give sucks? And the answer is probably yes. Usually they say, you don't get this upregulation of the receptors, you don't get extra receptors in a problem for at least 24 hours. So in the first 24 hours after the burn injury, you can use sucks and not have to worry about hyperkalemia. So the ER docs will use it, intubate, and then you're off and running. The patient's destined for months and years worth of medical care. So, but then the other question is, how long does it last? Now, when I was in school in the 70s, they used to say, well, after 6 months, you're okay. Patients probably get enough healing that they're not going to get hyperkalemia. So the time that you don't want to give sucks is after 24 hours, and then after 6 months from the injury. All right? Everybody see that? So we wondered, well, if you got more receptors, you got more hyperkalemia. Let's take a look. We had a chance to do it on this guy. And so this is what we did. We looked at, this is the number of acetylcholine receptors in the muscle biopsies, and you measure it in femtomoles per milligram of protein, and the normal level is usually right here. It's a little less than 10 femtomoles. And so this was on day 9, day 42, day 106. This is 3 months left after the burn. Look at this. He's really, really upregulated. Lots of extra receptors. He's going to have a really tremendous response to sucks. This is day 193, blah, blah, blah. And then look at this is day 568. This is a year and a half, going on 2 years later. And he's still got higher than normal level. So we concluded, I think you should conclude too, that there's probably no safe time. Once they have that major type of a burn, just don't give them sucks, ever. Now, you could say, why was it normal here, and then went back up? Well, these are different sites. We're taking the muscle biopsy from the place he's having surgery. So we didn't take the exact same muscle every time. So some parts of the body may not have upregulation, and still other parts that are more damaged may have it, and so on. The point is, his body has it. Don't give sucks. Question?
So this is for the patient with a 90% burn. Is there kind of a cutoff number that you would use for how
Yeah.
significant burn?
Good question. Look at the bottom of this page. 38. Burn patients, the second contraindication. This is a 35% total body surface area, third degree burn. So the general wisdom, in other words, and that's a great question because, if I burn my finger on the stove, do I not get sucks or something? So your question is very valid. So what's the cutoff? Well, the books and everyone else says about a 35%. So, as on page 38, to wrap it up, this shows upregulation of acetylcholine receptors in patients with a 90% burn, etc. Now, some of the pathologic conditions, some of the pathology that can be associated with hyperkalemia if you give sucks, an upper or lower motor neuron deficit, for example, quadriplegic or paraplegic, whatever. Prolonged chemical denervation. These are patients, let's say it's an ICU patient, It's been on a muscle relaxant for 3 weeks to keep them still in their bed. It's too long, but nonetheless it happens. They haven't moved, and all of a sudden they come to surgery and you give them sucks and they got upregulation. Direct muscle trauma, accidents and infections and so on. Burns, of course. Disuse atrophy. This is somebody from, let's say you get an oldie, little old guy or little old lady from the nursing home, and they come into the OR for release of contractures or bed sores, or you're doing some type of procedure, and they're in the nursing home all contracted up and being turned every 3 hours. And you've seen patients like this, you know the drill. And they don't move, they don't get up on their own, somebody picks them up and puts them in a chair once in a while. So they get disuse atrophy, their arms and legs atrophy, they get upregulation, don't give them sucks. They can have tremendous hyperkalemia. And sepsis, severe infection. So I'm reading this on bottom of 38. All these conditions have the potential to upregulate and increase acetylcholine receptors and therefore produce hyperkalemia. Okay? Alright, so then, all that in mind, what are some of the contraindications to the use of sucks? So here we go. Memorize these. Everybody who gives anesthesia needs to know these contraindications. You need to know who you give sucks to and who you don't. Everybody knows it. We all know it. Now you do too. If you want to play with the big boys and girls, then you gotta know the rules. These are the rules. These people you don't give sucks to. Okay? Here we go. Number 1, somebody with hyperkalemia. Duh. Burn patients, 35% total body surface area of 3rd degree burn. Patients with severe crush injuries or muscle trauma. Neurological injuries, paraplegic, quadriplegic. Turning the page, 39. Somebody with hyperkalemia due to renal failure. Now let me stop and talk about this. If somebody has renal failure and they're on dialysis, their potassium, of course, goes up and down with their dialysis. Now, if they, many times, in fact, the preferred thing to do is if somebody has no kidneys or failing kidneys and they have to come to surgery, they'll send them to dialysis first, dialyze them, and then bring them to surgery. If they do that, if potassium's normal, then you can give them sucks. If they haven't had dialysis and the potassium's high, then they can't get sucks. So it isn't the fact that they have renal failure that's contraindication to sucks. It's the fact that you have renal failure that causes hyperkalemia, and that's the contraindication to sucks. You see the distinction? All right, severe sepsis, muscle wasting, prolonged immobilization, extensive muscle denervation. These are the little old guy and lady from the nursing home kind of thing. MH. And next, Duchenne's muscular dystrophy. We're going to talk about muscular dystrophies here in a second. But I want to just don't write anything down. Just let me go off on a tangent here. There's several cases back in the 80s with otherwise looking people, kids look normal. Came to surgery for routine lumps and bumps, TNAs, hernias, whatever the kids get surgery for. Nothing major. And they got sucks for induction to intubate, and they had cardiac arrest and died. And there was, I think, when all the dust settled, about 14 cases in the United States. Very tragic, because these are otherwise healthy kids, looking healthy, having surgery that had a problem. So jumping to the end of the story, after much research and so on, the thing what was found out is the kids had Duchenne muscular dystrophy, and that's a muscular dystrophy where it doesn't manifest itself with symptoms till the kids are older, like 6, 7, 8 years old. So if they come into surgery at 3 or 4 years old, they look normal. Their parents think they're normal, everything's normal. And you go ahead and treat them like a normal kid, give them sucks, intubate, boom, they get tremendous hyperkalemia, because they had muscular dystrophy and you didn't know it, and they cardiac arrested and died. So, the FDA came out and said no more sucks in kids, and that's the way it stands today. So we don't give sucks to kids because of this scenario. First of all, you don't need to. You can usually, little kids, you can intubate without a relaxant. You can just bag them with CELO and then put a tube in them. It's no big deal. And older kids, you can use rocuronium. So we do not use succinylcholine in kids less than, say, 14 years old, or teenager types for any type of procedure. Now, because there's some pushback by us, the anesthesia community, to the FDA, they did loosen up their restrictions a little bit to package insert to say that in the case of an airway emergency, small doses of sucks are appropriate. So, because what we said is, yeah, okay, well, we can buy that. We don't need to use sucks anyway, so what's the difference? But if the patient has laryngospasm and they're 3 years old and you do them on a mask, an LMA, and you can't break the laryngospasm with positive pressure, then it'd be nice to be able to give 20 of sucks or 40 of sucks so you could break this laryngospasm. And the chances of this kid being an undiagnosed Duchenne muscular dystrophy is pretty remote. I mean, it does happen, but let's face it, it's not going to be your daily kid running into surgery. So the FDA said, yes, of course, that makes sense. So the current wisdom, the current package insert says, sucks is not used for, quote, routine intubation or airway management in kids, but can be used in a case of emergency. You can still use it if you need to intubate in a pinch. Okay, now, as far as muscle disorders go, let's take a look at page 47. Now, page 47, overflowing onto 48 and 49 is a table that I made up. And what I did is I scoured the literature, actually spent a couple weeks looking at every journal I could find in the world, European journals, non-English journals, everything I could find to answer this question. What about somebody with muscle disease? Do you want to give them sucks? So taking a look at my table, here's the muscle disorder or the disease, first column. Can they get sucks? What happens if you give a non-polarizer? Can they get regional anesthesias? Can they get gas? Are they susceptible to MH? You wouldn't want to give them gas. Are they susceptible to MH because of this muscle disorder? And then any particular kinds. So you can, of course, look up any of the muscle diseases. Look on page 2, myotonic dystrophy, multiple sclerosis, central core disease, filling number 3, every kind of thing I could find to put on here. And so rather than having to learn this, which I can and you can, and carry it around with you in your brain every time you go to work in the daytime, I can just say some generalities. I know you have a way to look things up and you have little pocket, information systems and phones with programs on them and so on. However, if you're in the middle of the night and you don't have time to look things up and somebody just woke you up and said you have an emergency appendectomy, you find out the patient has a muscle disease, what do you do? Well, let's start with sucks. Take a look at this table. What do you see? Contraindicated, pretty much, second page. Contraindicated. Third page. What do you see? I see a trend. I would say if you have a patient with any sort of muscle disease, don't give them sucks. That's a safe bet, right? You don't have to. You can get along without it. Just don't. Now with myasthenia gravis, they can still get it. Yes, I would. I wouldn't give it to them either. Just don't. This way you'll have a safe career. Always err on the safe side. Patient will like you for it. Look at the non-depolarizers. What about all these muscle diseases? Well, increased sensitivity. The more sensitive, the more sensitive. You're going to have to give less. They're more sensitive. Oh, next page, well, more sensitive. What do you see? It's not universal, but I would say in general, they're going to be more sensitive to the non-depolarizers. You're going to have to give less and be very careful on these patients. So if you have to paralyze a patient for this procedure because of the abdominal or chest or whatever it is that they have to be paralyzed for, you're probably going to have to give less of the non-depolarizer. You're not going to want to give sucks. That's kind of a general rule. Everybody see that? And the rest is there. And you can look at that. That's what tables are for. So, back to page 39, my contraindications. As far as select muscle disorders, C table, that's the table. And I would summarize it by saying, if I have some patient with a muscle disease, I won't give sucks. And I'd be very, titrate carefully, smaller doses of a non-depolarizer and expect the worst. The worst being they're going to have to be in a ventilator to recover. All right, this is what the FDA says should only be used in emergency situations in children under 8 years old, not for routine intubation. Yeah, we know. All right, another contraindication is anybody with an atypical cholinesterase. We just went through that in the first hour. That's kind of common sense, right? So anybody with a genetic variant for cholinesterase, you don't want to give them sucks. There is some talk about a drug interaction with statins. This would be big since every man in America is taking a statin once you get over 40. And so ensure that every day you go to work and you have patients coming in taking statins. And do they prolong? There's some question of whether, they have effects on muscles and they can make for prolonged action of sucks, and the answer is no. Forget about it. And then, of course, allergy. You can say allergy for every drug. Right? So these are the contraindications to sucks. Memorize them. In the test, I'm going to ask you these. Give me the contraindications to sucks. And you're going to tell me these things. I'm going to be happy.
So you said statins are not.
No. There's some talk about it. You may hear it or read it in the literature. I say it's not a problem. Yes.
For the severe trauma patients, is there the delay in upregulation that you also see with the burns, or is like that?
Yeah, good question. I don't think there's a delay is because the damage is immediate. So I would say if somebody had crush injuries, I would say don't give it ever. Unlike a burn, which would take the third shifting and the degeneration of muscle cells would take longer. Okay? Okay, good. That was fun. All right, this is a thing I got out of a book on the bottom of page 39. There's a reference at the bottom. I just thought it was kind of funny, but interesting. And this is talking about pre-treating prior to the administration of sucks. And again, we know that succinylcholine causes patients to depolarize, and that depolarization can cause myalgia post-op, muscle pain. It's more common in healthy people, especially women. If you can minimize it, why not? So we give a small dose of a non-depolarizer first, which helps. We call it pre-treating, or as some people call it, a defasciculating dose, whatever word they use. And that's just to make the patient less prone to myalgia post-op. And these are some other things they've studied to see if you could make the patient have less myalgia. Of course, non-polarizer, the effect that we know about. Vitamin C, have them do stretching exercises. I like to see that pre-op. Get off the cart, get down and give you 10. And you're not going to have muscle. Magnesium, lidocaine, and there's a whole bunch of things. Right? Basically, we use a small dose of a non-polarizer. Right? All right. Okay, that's enough of science. Let's go to page 41, and we'll talk about the non-depolarizers. And go through those. They're a little easier than sucks. And the non-depolarizers we break down, and everybody's using this nowadays because it's a Gamex. We break them down according to their chemical structure. So there's two types of non-depolarizers, chemically. One are called the steroidal non-drugs, because their basic structure looks like a steroid. And the other one are called the benzoyl-isoquinoline relaxants. This, look on page 41. These are the benzoyl-isoquinoline drugs. Atracurium, cisatracurium, mivacurium. So the ones that end in the word curium, C-U-R-I-M, at their name, are benzoyl-isoquinoline drugs. The ones that end with onium, pancuronium, rocuronium, vecuronium, the onium drugs are steroidal relaxants. They're the other chemical group. Now, this is coming into vogue again. It kind of comes and goes. Because Suhamedex reverses the oniums, but not the curiums. It cannot reverse the benzoyl-isoquinolines. It only reverses the steroid drugs. All right, and here's the structure, benzoyl-isoquinoline structure. I don't care. I'm sure you care even less than I do. But here's the structure. And you can see in the middle, the atracurium, cisatracurium. There's an ester link in there. That's, here, I'll go on the camera and point. I'll try to make you care more. I know you won't. This C double bond O here and this one here, those are ester links. Since they have ester links, they can be hydrolyzed, and the enzyme responsible for the hydrolysis is the non-specific esterases. Now, atracurium came out first. It's a pretty good drug. Worked pretty well, etc. Had a big drawback, histamine release. It's very annoying. So they found out there were several isomers of atracurium. It had various forms. One of the isomers, the cis isomer, had the same activity. It was a really nice relaxant and did not cause histamine release. So the company marketed the cis isomer of atracurium as cisatracurium or Nimbex, and Nimbex is atracurium without the histamine release. It's more potent. It's a pretty good drug, as it's calling, and it has no histamine release. That's the beauty of it. Now, mivacurium, again, as I said, generic house is bringing it out again this year. I think it's out on the market now. It was around in the 80s. Nobody used it because it caused histamine release, and nobody's going to use it this time either. But nonetheless, it's on the market, so I'll talk about it. But it's a benzoyl. The atracurium and cisatracurium. Atracurium is a dead duck. Nobody's really using it much anymore. Cisatracurium is still used quite often, and it's still available. Mivacurium, I doubt Kaiser's even going to buy it and put it on the shelves. You may run into it at one of our hospitals. I hope not. So those are the three benzoyl-isoquinoline drugs. They're all esters, and so they have non-specific esterase to get rid of. Okay, let me tell you this last story and I'll give you a break. When Atracurium came out, it had a unique metabolism, still does, nothing's changed. And it was designed to undergo what's called Hoffman degradation, or Hoffman elimination, or Hoffman metabolism, or whatever word you want to use. It's Hoffman. Dr. Hoffman is a chemist that this process, metabolic pathway, was named after. And he was back in the 1910s, way long before we were born. And he studied iron ore, how to make, in factories, how to make metals and so on. He discovered a process whereby you could get certain molecules to attack themselves and break themselves up. And they applied that to Atracurium and then ultimately Cis-Atracurium. And so what happened was, Atracurium and Cis-Atracurium metabolize themselves. They don't require any enzymes, no cholinesterase, no nothing. They don't require any liver, any kidney, anything. They'll metabolize themselves. What they do require is you initiate this breakdown by causing a change in the temperature the drug is in and the pH it's in. So here's what happens. It's easy. All right, you get a vial of Cis-Atracurium out of the drawer. Right, it's buffered in liquid. It's a clear liquid. You draw it in a syringe and give it. Just like most drugs, right? The liquid in the vial is buffered, the vehicle, to a pH of, I forgot, 5, something like that, a little acidic. And of course the temperature is room temperature. It's sitting in a drawer. When you inject it into a human being, the pH automatically goes to 7.4, because you gave it IV, and the temperature goes to body temperature rather than room temperature. So you've changed the pH the drug is in, and you've changed the temperature it's in. That in turn initiates this Hoffman elimination pathway that starts it. And certain parts of the molecule will start attacking other parts of the molecule, and it'll spontaneously break it open. So the whole selling point or beauty of Atracurium, Cis-Atracurium are that they don't require any enzymes or kidneys or livers or whatever. All they gotta do is you gotta be alive. If you're dead, it might not work. As long as the patient's alive, I don't care how cold they are, I don't care how acidotic they are, whatever. It'll still be enough of a change from the vial to initiate this Hoffman elimination and break the drug out. And so it's supposed to be more consistent, works the same in everybody. Whether you're old, you're young, you're male, you're female, you're obese, you're thin, whatever. The duration of action will be similar because Hoffman elimination is dependent on temperature and pH dependent hydrolysis. All right? Now, lastly, let's go to just quickly. Well, we'll take a break first. All right, let's get started again. Turn to page 43. Page 43. Page 43. Okay, the other type of non-depolarizer we, before the break, we said the benzoyl-quinolines, Atracurium, Cis-Atracurium, and Nivicurium, the curium drugs. The other type are the onium drugs, pancuronium, vecuronium, and rocuronium, and they're called steroidal relaxants because they have this basic steroid structure. This up and top is what a steroid looks like. Estrogen, progesterone, all the steroids in the body. And then you change the different groups around the outside. This is R1 here, R2, and R3, and R4. They're showing you which groups are changed for which drug. This is pancuronium, vecuronium, and rocuronium. So we don't care about that. We just care about the fact that they're steroidal molecules and called steroidal relaxants. So the take-home message is that the curium molecules, atracurium, cisatracurium, mivacurium, are benzoyl-isoquinolines, and the onium molecules, pancuronium, vecuronium, and rocuronium, are steroidal relaxants. Okay? Now, let's go to page 44. This is gold here. Right here. I sleep on this. I go home, I put my book on my pillow, I'd open it to page 44. I'd say, thank you, John, for writing this table. Because this is everything. This is all the metabolism for the relaxants. And why you pick a relaxant for any given procedure, one of the main reasons is you got to figure out how it's going to be eliminated. It's so important to get these relaxants gone at the end of the case, have 100% recovery, that you've always got to be cognizant of how they're eliminated from the body, so you're not giving to the wrong patient. If somebody has no kidneys and you give one that relies on the kidneys to be eliminated, then you got problems. It's an oh moment. So you've got to know the important thing. One of the important things to know about all the relaxants is their elimination pattern, how they're eliminated, so you know who you can give to and what. So let's go through these. We already have. Let's summarize. Number one, succinylcholine. It's classified as an ultra-short-acting relaxant, meaning it lasts 15 minutes or less. It's metabolized 98 to 99% with plasma cholinesterase. Therefore, the elimination via the kidney, less than 2%, liver, not really, and that's it. So it's pretty much metabolized in the plasma and at the neuromuscular junction too. But since most of it's in the plasma at any given moment, that's, they say, plasma cholinesterase metabolism. That sucks. We already know that. Mivacurium, it's a short-acting drug, benzoyl-isoquinolone. It's also metabolized by plasma cholinesterase. Less than trace amounts for the kidney and liver. Therefore, both of those depend on cholinesterase to be metabolized and eliminated. Now, atracurium, the intermediate relaxant, relies on both Hoffman elimination, and the part that doesn't go out from Hoffman elimination goes out because of non-specific ester hydrolysis. Now look, the Hoffman elimination story is a wonderful story. We tell it every year and everybody kind of likes it. I like it. But non-specific ester hydrolysis is 60 to 90% of the elimination. So Hoffman elimination is only 10 to 40%. But either way, it does make it very predictable. And no matter who you give Nimbex to, cisatracurium, it pretty much will last the same duration in each patient. Like I said, old, young, debilitated or not, obese or thin, whatever. It's pretty predictable. Most predictable relaxant, and that's nice. Because it does not rely on kidneys or livers or whatever. Cisatracurium, the cis isomer of atracurium, Hoffman elimination 77%, so that's a lot more. And non-specific ester hydrolysis 33%. Now, looking at the metabolites, there is some, just to mention this once and I'll never say it again, lodanosine and the acrylates. There are metabolites of Hoffman elimination and non-specific ester hydrolysis that you end up with metabolites, certain acrylates and lodanosine. They could be toxic if you had enough of them. There's no way to produce enough of them, so don't worry about it. All right, then the last three at the bottom, starting with vecuronium. It's an intermediate acting relaxant, of course, and it relies 30 to 40% on liver metabolism. less than 40%, around 40% is eliminated unchanged in the kidneys. See that? Some of it's, the rest of it, either the metabolite or the brand product is metabolized in the bile. So the liver, they say 60, the kidneys, they say 40. And of that 60, 30 to 40% is metabolized. The rest is just conjugated or just eliminated. See what I'm saying? The bottom line, the take-home message for us that have to work in patients is that it's about 50-50, right? 60-40, okay? Whatever. Kidneys and liver. So if somebody has kidney disease, the books will say it has an alternative pathway. If somebody has kidney disease, the liver can get rid of it. It's true. If the patient has liver disease, the kidneys can get rid of it, and that's true. But it's going to last longer in both those types of situations because you're eliminating at least one of the mechanisms. So vecuronium relies on both the liver and the kidneys to be eliminated. Therefore, you have to be very careful in people with liver or kidney disease. I'd give them Nimex if I was me. Rocuronium, of course, the world's famous, most popular relaxant. It's about 10 to 25% eliminated in the kidneys and about 60% in the liver. I'm sorry, 70% or more in the liver. So that's both liver and kidney, again, just like vecuronium, not the same percentages, but similar idea. Then finally, pancuronium. Look at that, 85% kidney. So it's pretty much a kidney eliminated drug. So pancuronium, again, hopefully it's in the dustbin of history, but again, every time I say that, then somebody sends me an email. I just used it yesterday afternoon. So if you do see it, it's still around. It relies pretty much 85% or so on the kidneys. So don't give it to people with kidney disease. Even though it has some liver metabolism, it's going to take 2 days to get rid of it. So I would say pancuronium is contraindicated in people with kidney disease. That kind of makes sense, right? So that's the gist of the metabolism and elimination of the various relaxants. And of course, I'll say it as I always say it, memorize this, because you need to know this clinically, so you give the right drug to the right people at the right time. Okay, any questions? On the next page, I put a little table in here, I don't know why. Yeah, question?
So would it be okay to give rocuronium to someone with kidney disease, or would
You can, it'll last longer, it's unpredictable, and you'll find, I think, when you practice clinically, you're not going to like it when things last too long. Because they end up on a ventilator. So that's the clinical scenario. So could you give it? Sure. It's not going to kill them, it's going to last longer. But what I would do is just give an index. It's easier. Okay, page 45, this is the same thing over again, I just wrote it out a different way in order to repeat myself so that you get mad at me. Here it is, atracurium on page 45. The elimination mechanism is, of course, often elimination and non-specific esterases. And the comments are it's a non-organ dependent elimination, produces consistent duration in patients with all kinds of things, significant hepatic, renal disease, old elderly patients, whatever. Atracurium, same thing. Rocuronium is both renal and hepatic eliminated, may be prolonged, therefore, in people with renal or hepatic issues. Vecuronium, same thing. Pancuronium is primarily renal, so don't give it to renal patients. And then succinylvecurium are cholinesterase, so they're going to be prolonged in patients with cholinesterase issues, either a deficiency or atypical. Okay? Next page, 46. Hey, we're knocking this stuff out, aren't we? Cool. Page 46. I want to talk about the cardiac effects. I did mention earlier last week that there really aren't any cardiac effects because they don't affect cardiac muscle, but they do produce some cardiac changes, or can, because of indirect actions such as histamine release, etc. So let's take a look at that. I'm on page 46. And in order to do that, I've just put this little thing on top. You probably noticed already from other classes, but just to review, there's actually three types of histamine receptors in the body: H1, 2, and 3. The H3s are not well defined. They have very minimal description as to their function yet, but certainly H1s and H2s we know all about. The H1 receptors, when you stimulate the histamine 1 receptor, you get increased capillary permeability. That's the swelling or edema that comes with histamine release. You get bronchoconstriction, intestinal contraction, and negative dromotropic effects means you have slower conduction velocity. You stimulate H2 receptors, you get a tremendous increase in gastric acid production. That's why you give H2 blockers for GI disease, Zantac and Prevacid, and Lord knows all those over-the-counters. They sell zillions of dollars worth. H2 receptors cause systemic and cerebral vasodilation and positive inotropic and chronotropic. So you get tachycardia and hypertension from the H2 part. So here's the sentence to memorize. Here we go. Somebody asks you about histamine release, like me, in relaxants, then this is the common wisdom, this is the conventional wisdom, and you're sticking to it. Atracurium releases histamine, modest amounts of histamine. And I didn't even write it in there. Oh my, I better change. We should say atracurium and mivacurium. So please add that in there. I can't believe I did. Atracurium and mivacurium cause histamine release. Therefore, and there's slight histamine release with SUX. Can get some with SUX, but we don't really consider it a major histamine releasing drug. The amount of histamine release is dependent on both the dose you give and the speed you inject it. That's true of any histamine releasing drug. If it's an opiate, if it's any type of drug, it's a chemotherapy drug, any drug that causes histamine release, the more you give of it and the faster you give it, the more you'll get. With endogenous histamine release, all receptors are elicited. You get both H1, H2, and H3. If you want to prophylax against, you know this drug's a histamine releaser and you want to block any possible problems, you have to give two drugs to block it. An H1 blocker and an H2 blocker. There's no single drug that does both receptors at the same time. What's the H1 blocker? You've all given it a zillion times. Benadryl. Thank you. Benadryl is an H1 blocker, and the H2 blockers, of course, are well-known: Zantac and ranitidine, famotidine, all that. So what happens when you get histamine release? Look on the bottom. The ultimate point I'm getting to, what are the effects? Well, atracurium causes histamine release. I'm reading on the bottom of page 46. Therefore, it can produce hypotension and tachycardia. And, of course, that's cardiac. It can also produce bronchoconstriction and breathing problems and rash and all the rest of that good stuff. Mivacurium, same thing. Causes histamine release and may produce hypotension and tachycardia because of it. Pancuronium is vagolytic, and it causes a little bit of catecholamine release. So it causes tachycardia. So pavulon tachycardia is a very famous effect of pavulon. In fact, people used to give it when they used a lot of narcotics to make the heart rate go up. because the narcotics were making the heart rate go down so much. But anyways, Pagilon causes tachycardia. Done. Finished. Because it's vagal, it's anticholinergic, it's whatever word you want to use. Parasympathetic. All that pharmacology like that. Then finally, succinylcholine can cause slight tachycardia when you give it. Usually that's what you get. However, repeat dosing in adults or any dose in kids can produce sudden abrupt bradycardia or any type of arrhythmia. We talked about that already. Okay, so that's the cardiac effects of the relaxants. Any questions? Pretty straightforward. Okay, let's go to the next page, 50. Skip over the table we talked about, the muscle disease table, and let's go to page 50. Now, I put this on here, there's a reference on the bottom, and this table says, page 50, factors that may prolong paralysis. Oh man, look at that. Memorize that. I'll have a test next Tuesday. I mean, there's an endless number of things. If you take a look at that, look at the, and I put it on there not to make you learn it, just to show you that who knows what's going to happen, right? So in the left-hand column, pathophysiological causes, these are all the disease entities the patient may show up with that could potentially make the relaxants last longer. So you take a look at some of those. The muscle diseases, of course, are going to be prominent in here. But of course, some other things as well, porphyria, renal failure, sepsis, tick bite paralysis, that'll be something. I had to put the patient on a ventilator, they had tick bite paralysis. Alright. Now what I did, this is from me, not the table, is I put in bold the ones I think that really matter, that you might run into in a real career. And in the left-hand column, of course, one I wanted to make sure and I'm not discounting the other ones are real, they are. They're pretty rare. One you see almost on a daily basis is hypothermia. So if the patient's cold, it's going to be hard to reverse them. That's a given. You can see that. You can be in anesthesia for 2 weeks and know that. That's a daily thing you got to do. You don't reverse them until you warm them up. Now on the right-hand side are drugs, pharmacologic drug interactions that may cause an issue. And I've gone down here and highlighted some that I think they're fairly, may be common or may occur quite often. Well, if you look at, starting at the top, aminoglycoside toxicity, penicillin toxicity, and as you go down here, you notice that antibiotics are prominent in almost all these little categories. So one of the big things that you worry about is patients getting antibiotics. Because antibiotics can cause muscle relaxation by themselves without the relaxants. And therefore, they can interact with the relaxants to cause an issue. Let's go on the next page, and I want to show you this. This is page 51, and I dug this up on the history book, but a 1976 study by Dr. Miller himself, and he was looking at the issue of antibiotics interacting with relaxants in surgery. Now, of course, we give a tremendous amount of antibiotics during surgery, pre-op, pre-treat, during the case. Oh, patient's septic, open the belly, they got an infection, got to give them antibiotics. We're always giving antibiotics to people. So they have high blood levels of antibiotics. We're using relaxants. There can be a drug interaction. Dr. Miller studied it. This is back in 1976. We've known about this for 50 years. This is no big mystery. Everybody who gives anesthesia knows this. So take a look at what his table is. We're not going to learn this, but I'll just show you. The antibiotic there on page 51, the left-hand part of the left-hand column was the antibiotic he looked at. And then he looked at, do they get neuromuscular block from the antibiotic alone? Can you antagonize that? And in the middle, was there an increase in the amount of relaxation if you gave a neuromuscular blocker? Then finally, could you reverse it with neostigmine, the interaction, or just giving calcium? Because the reason antibiotics can cause relaxation is they bind calcium. They have a chelating effect in muscles. They can bind calcium, and you lower calcium in a muscle, it relaxes. It's harder to contract it. So there's some experimental evidence in animals, and humans as well, that if you give IV calcium, you can reverse this interaction and get their muscle strength. So he was testing it. He was looking at that. That's why he puts a little column there with calcium. So what do you see? DTZ means D-tuberculari. That's a non-depolarizer. That's the only one we had in 1976. And SCH means sucks. So he's looking at sucks in the middle there and curare. So he's saying, let's look at the column on the second last column under neostigmine. Can you reverse this interaction with neostigmine? Oh, usually yes, sometimes no, partially, maybe on Tuesday. If you have a good lunch. What does this mean? Nothing. It's nonsense. Unless it says absolutely every time it'll never fail, that it's not doing you any good. You can't reverse it and say, well, sometimes it'll work. That might work partially. Oh, you'll breathe half the time. I mean, it's silly. And he knew that. I mean, he's not trying to pull anything over. Look at the calcium. Does calcium reverse it? Usually, yes. Sometimes partially. So in other words, let's get to the point. The point is this. There's an antibiotic muscle relaxant interaction that's well defined. We've known about it for over half a century. When the two types of drugs are given to the same patient at the same time, it can cause the patient to have prolonged paralysis. You go to reverse them at the end of the case, and they don't reverse. They end up on the ventilator in the recovery room, waiting for everything to wear off. That's the bottom line. What's the treatment if you have an antibiotic interaction with a relaxant and the patient can reverse? The treatment is always the same. I gave it to you. No matter what the problem is, the treatment's always the same. Take them to the recovery room, put them on a ventilator, give them some Versed, let it wear off. It'll wear off, the patient will be fine. Don't give calcium, don't be giving all this, who knows what. Bite the bullet. Question?
Are they resistant to reversal with Sugammadex?
Yes. They'll resist the antibiotics as well. Right, this is from Dr. Miller's current edition of the book. This little blurb at the bottom of page 4051, since he's the one who originally outlined this problem. Let's see what he says about 2018. Most antibiotics can cause neuromuscular blockade in the absence of relaxants. The aminoglycoside antibiotics, polymyxins, lincomycin, and clindamycin, primarily inhibit the prejunctional release of acetylcholine and therefore depress the muscles. Tetracyclines exhibit post-junctional activity only. When combined with the neuromuscular blockers, the aforementioned antibiotics can potentiate neuromuscular blockades. So at least when I studied it, we always learned it was the aminoglycosides. In pharmacology, the slang coffee room thing, the aminoglycoside, are called the mycin antibiotics. They end with mycin. Those are generally the aminoglycosides. Because the cephalosporins and penicillins have not been reported to potentiate neuromuscular blockade. Well, thank God, because guess what? 90% of the antibiotics we give in the OR are penicillins and cephalosporins. We use them like water. Ansef, you ever heard of it? If you're a nurse and haven't given Ansef within the first 15 minutes of nursing school, you're probably having a problem with something. So the cephalosporins and the penicillins are usually not an issue, fortunately. But we still see it nonetheless. Because antagonism of the blockade has been reported to be more difficult, if the administration of the aminoglycosides, ventilation should be controlled until the neuromuscular blockade terminates spontaneously. In other words, let it wear off. When you have a drug interaction, it doesn't make sense to give more drugs to the interaction. Now these two drugs are interaction, let me give two more. We'll see what that does. All right, it doesn't make sense. Just let it wear off. It'll be fine. Calcium should not be used to hasten the recovery of neuromuscular function for two reasons. One, the antagonism it produces is not sustained. And two, it may prevent the antibacterial effect of the antibiotics. So there you go. Let's go to the previous page and take a look. Some of the drug interactions. Well, penicillin and antibiotic interaction. You see steroids, IV steroids can interact. We'll talk about that here in a few minutes. With relaxants. Volatile anesthetics, we know that the anesthetics have a additive effect, at least with the neuromuscular blockers. When you go to reverse somebody at the end of the case, this you see right away when you give anesthesia too. Unless you blow off the gas, it's hard to reverse it. So you got to get rid of the gas as well as reverse the patient, etc. So they have an additive relaxing effect. Dantrolene, of course, dantrolene, the drug used for NH, because it's an anti-calcium drug, then it does interact. Magnesium and lithium also, being divalent cations, can interact as well. So those are the common drug interactions that you see. Okay, does that make sense? Now, page 52 and 53. I'm just going to show you this. Don't write any of it down. I'm not going to ask you any tests. This is an ICU thing. But what happened probably 20, 25 years ago, patients were getting prolonged administration of relaxants in ICU. They use them for the same reason we use them, to help make it easier to ventilate a patient who's ventilator dependent, to make them lay still so the nurse can take care of them, to relax the patient in general. And they were giving infusions, prolonged infusions for many days on end of the various relaxants. And they started to run into trouble when they turned off the steroidal relaxant especially, vecuronium at that time. Then they thought the patient would regain muscle strength now that the drug was gone, and they didn't. They had prolonged relaxation, even though they turned the drug off 12 hours ago, yesterday, whatever. Then they would call anesthesia and expect you to come out there and tell them why the patient wasn't moving. You bring a little twitcher box, and they'd still be paralyzed, and you go, oh, the patient's still paralyzed. There you go. And many patients had some issues. The FDA, of course, always gets involved, and they found out that it happened to well over 100 patients, and they stayed paralyzed for sometimes several days. You could imagine causing a drug interaction that makes a patient stay in ICU for an extra 5 days. That's a drug interaction that's costing $250,000 worth of medical expense, so it's an issue. So jumping to 2018, what they found out was this. The patients who are fairly ill, that are in ICU getting multiple drugs, especially steroids. We're receiving steroids in ICU and getting relaxants for a prolonged period of time. Get myopathy and the relaxants don't wear off. And so what they've done is say, first of all, don't use steroidal relaxants. Instead, use Nimbex. Let it wear off every once in a while and regain their strength so that it doesn't stay paralyzed for days on end. There's a whole little scenario. So let's take a look at page 52 and just read. I put a little brief statement on the top there. And so here it is. I'm on page 52. The clinical application of non-polarizers in intensive care include, but are not limited to, immobilizing patients for procedural interventions, decreasing oxygen consumption, facilitating mechanical ventilation, reducing ICP, preventing shivering, management of tetanus. Recent data in ARDS demonstrates that relaxants help get better. Cisatracurium may be kinetically preferred for the patients with organ dysfunction. For the obvious reason, cisatracurium doesn't rely on organs to get rid of it. It has more dependable release. Close monitoring with peripheral nerve stimulation is recommended with sustained use of non-polarizers to avoid drug accumulation. Reversal of paralysis is achieved usually by just discontinuing the therapy. Very rarely you have to give neostigmine. If you're using Nimbex, you can't give Sciamodex. It doesn't reverse the benzodiazepine equivalence. So, that's that. The next page, the American Society of Hospital Pharmacists, the main group that deals with drugs in the hospital, and they do a nice job. Their recommendations for use of relaxants in ICU, and I stick it in here just because, well, your ICU nurses make care. Avoid the use of relaxants by using more analgesia or sedatives. Manipulate the ventilators so that they tolerate ventilation. In other words, overbreathe them and take over. So you don't have to give relaxant. If you do give relaxant, minimize the dose. Don't give it more than 2 days in a row. Use it by bolus rather than infusion. Why do they say that? That's contrary to most pharmacokinetics. When you want to give a drug and they have a fine alignment, you want to give it by infusion. That's why we use infusions. They're saying give it by bolus. Because they're saying that because what will happen is the nurse will not get over there in time to give the next bolus because they're giving a report to the next shift where they went to lunch and they may skip a dose or the dose will be a half hour late. They'll wear off and that's a good thing. You want it to wear off every once in a while. So they're saying, oh, it'd be better, let's do it by bolus. This way it's more uneven and you'll actually get it to wear off. There you go. Administer only when required to achieve a well-defined goal. Allow recovery from the paralysis. Consider alternatives, etc. Avoid Vicodin. So there you go. Okay, and finally, I'm going to go to page 54, and we'll do this, and then we'll wrap it up there. Talk about dosing. We've talked about dosing before, and you learned doses, and you've given our doses already. But let me just show you what Dr. Miller talks about for his dosing stuff. This is his chart, exactly, word for word out of his textbook. And so look what he does. He says, well, there's the drug. Then he says, ED95 if you're giving nitrous and oxygen. So this is a patient who didn't get anything else. They're just getting nitrous, so there's no relaxation from the gas. And so you just paralyze them. Here's the next column is the dose for intubation. The next column is the dose after intubation. So this is somebody who's already got a tube in. You maybe gave sucks to intubate them or whatever you did. Somehow the tube got in, or they came from the unit with a tube in. And you just need to paralyze them for the case after they're already intubated. There's your dose there. Then what if you're using nitrous? What if you're using anesthetic gases? This means volatile anesthetics. Well, look at all those numbers. My. There's a drug mistake waiting to happen. All written all over it, right? The simpler you can make it, the more consistent the dosing, the less chance of a mistake. That's true all the time. So let's cut this down a little bit. Now, what he's talking about, see the little sub A underneath? Suggested doses provide good inhibiting conditions under light anesthesia. similar to what it would be like if you gave sucks. B, as far as the anesthetic gases go, potentiation of non-polar relaxants by different anesthetic vapors, love that word, vapors, has been reported to vary from 20 to 50%. That's a lot. Recent data suggests, however, this variation may be much less. For the sake of simplicity, this table assumes a potentiation, and that's the wrong word. Of course, you know that. It's not potentiation, it's an additive effect, of 40% in the case of all anesthetics. Now, if you're going to give sucks to somebody, and I mentioned it before, the 8095 of sucks is about 0.4 something, I forgot. The average person you can usually intubate at about 0.6 per kilo. Since we pre-treat, we bump it up another 20%, usually to 0.8. And who wants to figure out 0.8? You might as well just use a milligram per kilo. That would be around 70 kilos. So why don't you just give 100? That's what we do, right? A milligram to a milligram and a half per kilo, and a milligram and a half per kilo in a 70 kilo patient would be 100 milligrams. Give everybody 100 milligrams for the rest of your career. I'm telling you, it'll always work. The one nice thing about sucks that keeps it on the market, despite of the issues associated with it, is its predictability. It is the most predictable drug you'll ever use. It works in everybody all the time. 45 to 60 seconds, they'll be paralyzed 100%. Man, it's unmistakable. And if you give 100 sucks, you'll get everybody. Big guys, little women, big women, doesn't matter. Size, disease, age, just give them 100 milligrams. It doesn't matter that much. Remember, these are 100% water-soluble drugs. Right? Because of a quirk in their chemical structure, they're always 100% water-soluble. Doesn't matter what the pK, pH, all that stuff is. They only stay in the body water. The body water doesn't vary that much person to person. You can have a big guy, 250, and a smaller guy, 150, and yeah, their weight's a lot different, but it's not the body water that's that much different. It's muscle mass and fat and so on and so forth. So all you got to do is just give the same dose to everybody. Just give 100 milligrams. Make it easy. There won't be any mistakes. Move on. All right, next. You go to the non-depolarizing relaxants. If you're not going to use sucks to intubate, what are you going to do? You're going to give rocuronium. Why? Because it's the fastest onset of all the non-depolarizers. So this is what everybody does. I'm not just me. I'm just talking about everybody. If you don't intubate with sucks, plan B is always rocuronium. You'll see that the normal relaxing doses of rocuronium, take a look at that. ED95 under nitrous and oxygen, rocuronium. Normal ED95 is what? If the patient's just going to be relaxed. 0.3. 70 kilo patient, how much rocuronium is that? It's about 20 milligrams, right? If you're going to intubate with any of these drugs, they just multiply it times 3. You give 3 times ED95. That's how they come up with the dose. So what's the intubating dose of rocuronium? If the relaxing dose is 0.3, and the intubating dose is 0.9, right? Who wants to use 0.9? Not me. Run it to 1. Just give 1 times their weight. If they're 60 kilos, give them 60 milligrams. If they're 70 kilos, give them 70 milligrams. Make it easy. You won't make a drug error. 0.9. Oh man, let me figure that out. Does it really matter? Is it that exact? No. So give 3 times ED95. All you're doing is giving up more of a drug just to get it to work faster, right? The more you give, the faster it works. Now the downside, of course, is the case has to last long enough for the 3 times ED95 rocuronium to wear off. And the normal duration is the intermediate relaxants are what? 45 to 60 minutes. 3 times ED95. You know you're way over 100% paralyzed then. it's gonna take an hour, good hour and a half, 2 hours before the patient gets anywhere near reversing time. So hopefully it's a long enough case. They usually are. So that's rocuronium. Now cisatracurium, you see it's 0.05. Vecuronium is 0.05, so it's just the same. That's easy. So all you gotta memorize is succinylcholine is 100 milligrams. It's a milligram and a half per kilo. Rocuronium is 0.3. Intubating dose is 1. Vecuronium and cisatracurium are 0.05 each. Look at nivacurium, 0.06. I'll make it 0.05. I won't tell. It's not that big. So that's pretty much it. You can memorize them all. I got all those numbers on the table. I'll give you 5 numbers, and you can give anesthesia for the rest of your life. Everybody see that? All right, we'll pick it up here next week when we come back. I'll see you next week.